Good morning. My name is Dr. Jeff Yu, and I am the Chair of Dermatology at Virginia Commonwealth University in Richmond, Virginia. My main area of interest is allergic contact dermatitis, especially in children. One of the sessions that I've been running for at least the last 4 or 5 years now is a session on pediatric allergic contact dermatitis, really focusing on how we diagnose allergic contact dermatitis, how we screen for allergic contact dermatitis in children, what kind of kids should be screened for allergic contact dermatitis, and what are some of the most common allergens that we are dealing with today. So I think the tides have been changing a little bit where we're really starting to recognize that allergic contact dermatitis can occur in children more and more. I think there are more people who are patch testing or diagnosing allergic contact dermatitis in children, figuring out what allergens they're allergic to, or at least thinking about what allergens they're allergic to. So I think that the main takeaway here is that I think we still need to keep up the good work in terms of making sure that we're screening kids who have maybe a little bit of atypical eczema to think about maybe this could be allergic contact dermatitis. What are they coming in contact with and how do we best avoid it? So the only definitive treatment for allergic contact dermatitis really comes from avoidance. But that being said, a lot of the symptoms of allergic contact dermatitis, the eczematous rashes, the itching, the discomfort, some of that can be treated with some of the therapies we have available today. For mild cases of allergic contact dermatitis where maybe we can't avoid the allergen or we don't know the allergen, topical medications, topical steroids, topical PDE4 inhibitors, topical JAK inhibitors, anything that's been FDA approved for atopic dermatitis oftentimes will also work for contact dermatitis. When they have very severe contact dermatitis, maybe that's systemic, maybe that's body-wide or refractory to topical treatments, then we really start thinking about some of the biologics that we currently have involved, including some of the AD biologics perhaps, maybe some of the oral JAK inhibitors. Some of these broader immunosuppressants oftentimes will work very well for allergic contact dermatitis that's either refractory or we can't identify what's causing it. Well, like anybody who has allergic contact dermatitis that goes untreated, I think a lot of times people assume that maybe this is atopic dermatitis, maybe this is a form of eczema. So the long-term prognosis is really living with the disease like you do in AD. And oftentimes these kids unnecessarily go on either long-term topical steroid use or some sort of a systemic therapy that maybe they don't need to be on in the first place. I think we don't really know what happens to contact allergens over someone's lifespan yet, right? We don't really know if they lose these allergens. We don't really know if they, at what rate they acquire new ones as they get older. We also don't really understand exactly what the natural history of a contact allergen is, because once we identify it, ethically we kind of try to get them to avoid it, so we're not really following it over time. So my guess is these contact allergens are probably stable over the course of their life, especially if they're constantly being exposed to it. One example would be something like lanolin, which is a very common allergen that we see in some moisturizers, and these moisturizers are oftentimes used for kids with atopic dermatitis. But if you constantly use it, they're really not going to get any better. And unless you know that the moisturizers was causing the rash, you're not going to know how to avoid it. If you don't know how to avoid it, you're going to keep using it, so the kid's going to constantly have this rash. And you're going to think maybe they just have really bad AD. But then once you have that diagnosis, they're probably going to go on some sort of a systemic therapy. AAD I love because it is a wonderful kind of just mixture, kind of a little bit of a hectic mixture of education as well as social events. One of the things I always look forward to is some of the excellent educational sessions that exist, but beyond that, certainly reconnecting with old friends, reconnecting with colleagues, really working with new partners, either that is in industry or in academia, figuring out new connections and really seeing how we can bring new treatments to patients with various types of derm diseases. A lot of the work that I do centers around how can we figure out better ways of diagnosing contact dermatitis. That's something that we're actively working on. Clinical trials is something else that we're very heavily involved in, especially for some of the rare diseases. Even though my clinical niche is really in atopic dermatitis and allergic contact dermatitis, I think we really have to think a little bit beyond that when we're thinking about bringing therapies to patients that have diseases that maybe don't have great therapies. Thinking about things like vitiligo, thinking about things like hidradenitis, thinking about things like lichen planopilaris, which is one of the clinical trials that we're actively involved in. There are no treatments for it yet. So I think anything that we can bring to patients can do a significant amount of good.